Thank you,
Okay.
Amalpreet.
Okay, so starting with the case, today we have a case where the main chief complaint is shortness of breath for 1 day. Regarding a little bit of history of present illness, it is basically a 53 years old lady who presented with shortness of breath for 1 day. And she said that she was in her normal state of health till yesterday when she started experiencing sudden onset dyspnea, which is now present on rest and exacerbated on exertion. Therefore, emergency services were called, and the patient was found to be hypoxemic, requiring supplemental oxygen. Therefore, the patient was admitted to acute care and required supplemental oxygen up to 4 liter on nasal cannula. Regarding the ROS, we know that the shortness of breath was present, but the chest pain, cough, fever, nausea, vomiting, abdominal pain, dizziness, and lightheadedness was absent. So this is the first aliquot.
Oh, all right. This is a really, really exciting start. I will say that I think one of the things that jumps out to me from the beginning here is the fact that this is a sudden onset clinical syndrome. And I think it's worth having just a general framework that we can use for very sudden onset symptoms, and then we can apply that framework to the problem of shortness of breath here. So if we think about what types of diseases tend to lead to symptoms to onset very, very suddenly, there's really sort of three types of pathologies that can do that, right? Something can suddenly be blocked, something can suddenly be ruptured, and there can be a sudden discharge of electrical activity, right? So if we think about sudden onset central nervous system symptoms, right, we might think about something being blocked like a blood vessel. Stroke is a sudden onset symptom. We might think about something rupturing. Intracranial hemorrhages or intraparenchymal hemorrhages can be sudden onset symptoms. And then seizures, like an electrical activity impulse, can also be a sudden onset neurologic symptom. So we can use this framework as we think about applying it to shortness of breath as well, which I'll turn the mic over to you, Sharmin, for. But one caveat that we want to make here is before we really settle in on this being a definitively sudden onset syndrome, we have to be open to the fact that the disease may have been brewing for some period of time and just suddenly came to the patient's attention, right? There may be some diseases that slowly build and then they come to the attention of the individual suddenly, whereas sometimes it actually is indeed something that suddenly started. And this can oftentimes be obtained in the history where we're like, if you go back and really think about the last few weeks, have you been having any low-level shortness of breath? And sometimes they're like, well, maybe I've been feeling a little bit off, but it's much worse today. That's a different scenario than when they're like, I was fine this morning, and then I became very, very unwell all of a sudden. And so again, we can think about blockage, rupture, and electrical activity as the sort of sudden onset syndromes, and then we can think about how we might apply that into the chief concern of shortness of breath.
Oh, I love that, Jack. And I really love also holding that tension of whether this is now patient is recognizing it or whether it's truly acute onset. And I think, just for a thought exercise, and again, like you want to center yourself in the most urgent and also your no misdiagnoses. And oftentimes that falls into like acute onset of symptoms. So, she's been dyspneic, and based on the information we now know, she's hypoxemic. So for now, if I'm the first person seeing this patient, I would frame it as an acute hypoxemic respiratory failure and kind of like invoke that reasoning process. And when it comes, and using Jack's framework, when it comes to acute hypoxemic respiratory failure, two organs that I think first of is your cardiovascular and your pulmonary organs that might be involved. And thinking about things that are getting blocked, she doesn't complain any chest pain, but acute coronary syndrome is one that can present with acute onset hypoxemia. Again, for women, especially older women, atypical presentations are quite common. So thinking about the vessels being blocked, arrhythmias, as Jack mentioned, electrical discharges, and thinking about blockage as well, thinking about pulmonary embolism as a cause of hypoxemia, like so cardiovascular, like blockage in the vascular of both heart and the lungs are two of the most important ones to think about. And then thinking about the pulmonary itself, tension pneumothorax, again, I guess that could be a rupture. I would put it under the rupture category.
For sure.
And then thinking about, if there's an underlying pulmonary disease, like your bronchitis from your asthma to COPD exacerbations, and thinking your pulmonary tree is another etiologies that often comes to mind. So again, for this patient, taking a listen to make sure you have bilateral breath sounds. What do you actually hear? Getting an ECG in the first go around and vital signs will help you differentiate how fast we need to move towards these different categories. Again, hypoxemic respiratory failure, quite of a large bucket. However, starting off with things that requires the most urgent treatments. Anything to add to that, Jack?
No, I'm totally with you. I think like the exemplar diagnoses from each of those categories are the exact ones, the exact same ones that I have. So yeah, I love that. I think we may have to go through deeper and deeper layers, but I think those are all the things that we would exactly be thinking about up front. So I'm with you.
Okay, so amazing discussion. Thanks a lot. And talking about the past medical history, the patient has a history of a long-standing heart murmur. And apart from that, there is no other significant past medical history. Therefore, the patient is not on any medicines. Her father had a history of hypertension, and there is no significant history in mother, and no significant surgical history as well. The patient, as we know, was from Central America, and she never smoked and had no known allergies. Regarding the physical examination, at the time of presentation, the blood pressure was 120/90, and the heart rate was 90. Then respiratory rate was 22. Saturation was 96% on 4-liter nasal cannula, and the patient was afebrile. Then the general examination of the patient, that she was well nourished. Pupils were normal, bilaterally equal in size and reacting, and there was no evidence of icterus with normal conjunctiva and no jugular venous distension. Regarding the cardiovascular examination, the patient had normal S1, S2, and grade 4/6 systolic murmur in the upper sternal border. Then pulmonary examination was clear breath sounds bilateral. Regarding the abdominal examination, bowel sounds, they were present, and the abdomen was soft, non-tender to palpation. The neuro examination was fine as well. The patient was alert and oriented ×3, fluent speech, and answered the questions appropriately. And in the extremities or skin, there was no clubbing or cyanosis and no evidence of any edema in the extremities. That's it about the second aliquot.
Thank you so much. I think there might have been an issue with my internet. I didn't quite hear the pulmonary exam. Would you mind just repeating it?
Yes, regarding the pulmonary examination, there were clear breath sounds bilaterally with no wheezes or crackles.
All right. Thank you so much, Anilpreet. I'll focus on kind of like background history and then pass the mic to Jack to walk us through the exam. So, not much there. So whenever I see someone with not that much robust of a past medical history, one thing that I always think about is like, is this someone who regularly has access to care or not? Because if there's someone who doesn't regularly have access to care, it just means like they might have some chronic medical condition that has yet to be discovered. And the one thing we know about her is that she has a history of a heart murmur. And I'm thinking about whether that is a red herring or could be part of the clinical syndrome that is she is presenting with. So, if thinking about if this it's like a simple like mitral valve prolapse, or she has history of like a bicuspid aortic valve and has as a higher risk of developing like AS. In the setting of AS, you'll think about like flash pulmonary edema as a possible etiologies. Structurally abnormal heart are more likely to be destroyed or affected if there is a concern for an infection or endocarditis and like the septic emboli as well. And thinking about the other etiologies, like does that put her more at risk of like heart failure? So this is like a couple of different ways to think about like incorporating a murmur into the presentation. However, it could not be related. And if this is in fact AS, then the other thing, I worry about these people when they go into arrhythmias because they have a fixed obstruction that we have to worry about. In terms of like, being from like Central America, then thinking about like, and possible exposure that's just had in the past. Again, I'm not going to pull on that thread, but just like kind of acknowledging it and see later on if that becomes an issue. And thinking about, cardiac etiologies that you can have access to, whether it is like rheumatic disease, Chagas, or things like that. Again, we don't know until we get a little bit more information. And thinking about like being at risk for like emphysema, COPD, having a non-smoker, again, like lowers the possibility that those things are at play, although doesn't eliminate it. Again, you can have antitrypsin 1 deficiency as another way to pneumothorax. However, I'm trying to ignore the physical exam finding and just focus on the past medical history. Jack, what are your thoughts on the exam?
Yeah, I think this is a super interesting exam given some of the pathologies that we're contending with here. I would say I think the primary thing that I'm grappling with in my mind right now is something that I think can be a challenging question in this case because it really influences how we frame it, which is what is the significance of this very loud murmur we hear on exam and the longstanding heart murmur in the past medical history, as you mentioned, Sharmin. I think if we were to sort of use the anatomic textbook here, we would say that this is probably an aortic stenosis murmur. But I will say, like, I have heard many a mitral valve murmur in the left upper sternal border. And so I think like in the textbook, certain murmurs should be heard in certain areas, but practically we can hear murmurs throughout the precordium oftentimes, particularly when they are that loud. And so the framework that I'm using in my mind is just to remind myself that the systolic murmurs include stenotic murmurs through the aortic and the pulmonic valves and regurgitant murmurs through the mitral and the tricuspid valves. Again, just to repeat that, systolic murmurs will be stenotic murmurs through the aortic and pulmonic valve, and regurgitant murmurs through the mitral and the tricuspid valve. The left side murmurs tend to be much, much louder than the right-sided murmurs because it's a much higher system. And so thinking about, as you mentioned, Sharmin, could this be aortic stenosis or could this be mitral regurgitation? If we sort of run through the exercise of saying which of those is most likely to be very sudden in onset, I would say probably mitral regurg is likely to be sudden in the setting of what can potentially be a spontaneous complication of mitral regurg or a post MI complication or intra MI complication of mitral regurg, and that's an acute papillary muscle rupture. And an acute papillary muscle rupture can cause a very sudden onset shortness of breath and hypoxemia. But one piece of the exam that doesn't fit well with this is the fact that she has clear lungs on exam, because acute MR with a flail leaflet or with a papillary muscle rupture leads to basically the dumping of systolic ejections back into the pulmonary circulation and into the lungs. And so the fact that there's hypoxemia and clear lungs makes the possibility of pulmonary edema from either an acute mitral regurg or a progression of the aortic stenosis to the point where it's now critical a little bit less likely for me. If this was dyspnea alone, we may say, okay, we're just not in the space yet where regurgitant blood flow or vascular congestion is filling up the alveoli, but we have pretty prominent hypoxia here. And that makes me think about, well, gosh, hypoxia with clear lungs, it's pretty hard to make an argument for the heart here, because oftentimes when the heart causes hypoxia, it does that by way of pulmonary edema. And so I'm sort of like, okay, the valve is possible, but maybe not perfectly compatible here. So what other disease processes can cause hypoxia with a clear lung exam? And those tend to localize to the vasculature and the right ventricle. PE may have clear lungs on auscultation, but lead to pretty impressive hypoxia. And then acute pulmonary hypertension, either from a pulmonary embolism or something else, can also sometimes lead to hypoxia. The times we often see this is the decompensation of long-standing pulmonary hypertension, which we don't necessarily have in this case, and that tends to not quite be as sudden. So I think if we say the sudden factors here of hypoxia on exam, clear lungs, and a sudden onset syndrome, the ruptured papillary muscle rupture or the blockage of the aortic valve are falling in favor of something that's going to give us a clear lung exam, which I think seems more likely to be PE. But in reality, right, like there have definitely been infiltrates on chest x-ray that I have not heard on the exam. So all of these hypotheses are still in play, but I think that's how I would frame the priorities at this point.
Really wonderful. Thanks a lot. And regarding the labs, moving over to the next aliquot, HP was 11 with MCV of 89 and RDW of 13. TLC was 9,000 and sodium was 138. Potassium was 3.8 and chloride was 103. Bicarbonate was 24. An iron gap was 6 and calcium was 8.2. Phosphorus was 2.2 and magnesium 2.6. The RBS reading was 120 and creatinine was 0.6. The COVID test was done, which turned out to be negative. And then pro-BNP was also done, which was found to be 1400, 1400. And troponin was 66 on admission, which got to a peak of 300. Do you want me to stop here or should I give a little more data? Do you want to reflect on the labs for some time?
I think we can talk a little bit about the labs here. Amalpreet, I know that this is a case that was sent to you, so totally okay if you don't know this, but do you happen to know what the units of the troponin were here? Was it the high sensitivity troponin or?
Looks like high sensitivity.
High sensitive. Okay, great. That is helpful to see. Thank you. I think just sort of looking at the labs in general, maybe I'll just sort of narrow it on like what types of labs can really help us make progress when we're evaluating the acutely dyspneic patient. And I think there's not too many of them that can really help us make a ton of progress. I think the white count can certainly help because obviously infections can cause acute dyspnea. And then beyond that, I think the ones that I tend to find myself looking at the most is the bicarb, because the bicarb can give you clues into one of the non-cardiopulmonary causes of acute dyspnea, which is going to be anacidosis, but it wouldn't necessarily explain hypoxemia here. And then the other thing is that sometimes we can actually get the clue that maybe there's actually pre-existing lung disease that has gone underdiagnosed. For example, sometimes people have obstructive lung disease, chronic CO2 retention that gives them a sort of a baseline compensatory metabolic alkalosis. And there have been times where there has been evidence of that underlying lung disease that the patient hasn't necessarily reported. And so I think those two labs, if we're looking at them here, can give us some clue into, again, what is the cause and potentially the duration of this problem and an alternative etiology that might be at play. We see that the bicarb is relatively normal. The white count is relatively normal. So it's not helping us a ton here with making progress, but I'll turn it over to you, Sharmin, for some of the cardiac labs that may help us make some progress here.
Ooh, thanks, Jack. I love the bicarb discussion. So we have an uptrending troponin and elevated pro-BNP. Based on like Jack's previous discussion, one thing that we were debating on from the get-go was like whether pulmonary embolism. And, I have a hard time thinking that this patient is not going to get a CTA because she's coming in with acute hypoxemic respiratory failure with clear lungs. And the caveat I always like say about lung exams is not perfect, and it depends on how deep the patient is taking a breath. So I always take clear lungs with a grain of salt. However, in this exercise, clear lungs makes you think about vascular pathology, and in a setting of elevated trope and a BNP, then it makes you think about high risk PE. Again, before even doing that, before getting the CTA, what you want to do is an ECG in this patient. Because again, in women, oftentimes atypical presentation at ACS are common, and you want to make sure we're not dealing with an acute coronary syndrome here. So getting the ECG first, keep trending the blood pressure for this patient, especially if you're worried about a high risk pulmonary embolism. And then the other thing to think about is other causes of like troponin elevations. But again, those two are the first two things that I want to rule out. And then if the CTPE comes back negative, if you're not working about acute coronary syndrome and PE, then we can invoke about myocarditis. We can wax politically about other causes of elevated troponin. But off the get-go, those are the two things that I want to make sure we are dealing with. And in terms of like other things that can be done, when with the elevated troponin and a BNP, if this is PE, it makes me already concerned about some right heart strain. But getting an echocardiogram is oftentimes helpful as well in this patient. Again, I might not have it urgently, but it would be good to have a better understanding of that murmur. And in addition, if you're worried about PE, getting a better view of the right heart. The other thing to think about, and these patients are like shunt as well, and intracardiac shunt would be another thing to think about. So yeah, those are going to be my next steps. Anything to add, Jack?
No, I think the only thing is I think there's sometimes we get studies like the CTA to specifically go and looking for a certain pathology, and then there's some things that sort of we get lucky and discover in the moment. And I think there's been one case where where we thought it was going to be a PE, and we're surprised to find that it was actually an aortic dissection, and it was a case where there was like no chest pain, no hypertension, none of the characteristic features. And I think that moment, what that moment highlighted for me was not like, oh, we should have been prioritizing an aortic dissection in an illness script that really doesn't fit. But I think what it reminded me of is like, oh, we get so much more data from the CTA than just the answer of exploring the PE, because there's so many devastating, or I shouldn't say so many, but there are quite a few devastating intrathoracic diseases that the CT can pick up, right? The chest X-ray negative pneumothorax, the atypical aortic dissection presentation, obviously the PE, and then sometimes we get lucky and sort of find those things that we weren't even thinking about. And so I think just saying that like a lot of times we are like, do I need the CTA based on whether or not I think they have a PE? And that is one way to look at that question. But the other thing is to say, is there potentially a catastrophic intrathoracic disease that we haven't formally falsified yet in the absence of a compelling alternative diagnosis? And I think both of those questions are at play here, making the case for getting the CTA.
Yeah, I love that. And I think this is one of the cases that you want to get that imaging as fast as possible, because depending on what you see is going to vastly change your management of this patient. So this is someone who's right now hemodynamically stable. So I would want to get as much data as I can so I can also think about like how I want to treat this patient. So I honestly wouldn't do anything until that imaging is done. So I know I'm treating the right right? Like you don't want to give load to someone with aspirin if you're worried about a dissection, right? So yeah, I totally agree with you, Jack.
Great discussion. And the next aliquot, after this, I will reveal the diagnosis. The chest X-ray basically showed mild pulmonary vascular congestion, no focal consolidation, and no pleural effusion or pneumothorax. The heart appears enlarged, and EKG showed normal sinus rhythm with left ventricle hypertrophy with non-specific ST wave changes. And regarding the CTPE, it was negative for pulmonary embolism and was significant for the diagnosis of this patient. So any final thoughts before I reveal the diagnosis?
All right, Jack, we can just maybe talk about this aliquot together. So I'm really grateful to get an ECG. Again, this is something to trend, right? So as you're trending the troponin, trend the ECG, especially with like some of the non-specific ST segment abnormalities, then you, as the PE becomes lower, then you want to think about, again, are we dealing with an STEMI in this case? And the hypoxemia and the chest and the shortness of breath is an anginal equivalent of that. And, with the CT chest, that was like negative for pulmonary embolism. Again, we're thinking about ACS still. PE is negative, which was our likely thing. And then again, I think the focus goes back into the heart, especially if the parenchyma in the CT. Was there a comment on the parenchyma annual preat for the chest CT?
Yes, currently we're just, it was basically CTPE as documented, and negative for pulmonary embolism and significant for a particular diagnosis.
Okay.
We have to solve the riddle. We have to solve the riddle.
Gotcha. All right, perfect. So, thinking of what could it be, right? So, someone who's coming in with elevated troponin, with elevated BMP, in terms of the lung findings, as you mentioned, Jack, like pulmonary edema would be the one. We didn't hear any crackles, but if there is especially effusions and edema, thinking about the acute onset heart failure is one thing. I think, again, ACS is one thing that still on my mind. And then acute valvular pathology. And one thing that you mentioned, Jack, about like something being chronic in the background and then having an acute trigger. If she has really bad valvular pathology, venous arrhythmia, or have a sudden onset in blood pressure that caused a flash pulmonary edema. Or, a dissection is another thing that, as you mentioned, to think about. And then in terms of like intracardiac pathologies, shunt is one to think about. Making sure she's not in tamponade is another one, especially with the cardiac fluid that is enlarged, are the ones that I'm thinking about. What are your thoughts, Jack?
Yeah, I'm with you. I think this is a really, really fun exercise to be like, okay, how can we have hypoxemia in the chest, which with a relative, or hypoxemia with a relatively unremarkable chest X-ray and no PE? And I think I'm going through the same exact analysis as you are, which is to say, like, that mild pulmonary vascular congestion we may discover looks moderate to severe on the CT scan, and maybe there's more pulmonary edema than the chest X-ray showed, and then the exam showed. And then the other thing I'm going through is like, well, what other diagnoses could we potentially pick up on the CT that weren't seen on the chest X-ray? I think one of them is sometimes there can be very, very subtle pneumothoraces that aren't seen clearly on chest X-ray that are much more visible on the CT scan. But I also don't know that if that would be enough air to lead to this degree of hypoxemia. Aortic dissection, again, sort of remains in play just because all of the other things that have been ruled out. And I'm sort of going through my mind and being, well, gosh, how could we elaborate a mechanism by which dissection could cause hypoxemia? And I think this is just sort of riffing on this question. I think one way that we could do it is to say that if there is sort of coexisting aortic regurg that develops as a result of the dissection, you could start to get some heart failure. And again, maybe there's pulmonary edema that's exam and X-ray negative, but CT positive. The other sort of very, very feared complication of an aortic dissection is that sometimes it can dissect all the way down into the coronary cusps and into the coronary arteries. And if that starts to involve the right coronary artery, you could see the RV start to fail, and you sort of get a picture of RV failure up front, which, as we said, individuals who have pulmonary hypertension acutely or chronically can sometimes get hypoxia by that mechanism. And then I'm just going through, are there other things? Yeah, I feel like the subtle parenchyma thing, the subtle pleural thing, particularly air, and then the devastating vascular diagnosis of an aortic dissection would be the things that I would run through. And of those things, I feel like a dissection is the most likely to cause this degree of hypoxemia because it probably has the most mechanisms by way that it can do it. But that's tempered by the fact that this presentation is so inconsistent with what we characteristically see. So I think I would, I think those would be the things that I would have in the back of my mind here, sort of waiting to see what the radiologist's final read is.
Yeah, I
Yeah.
totally agree. I think like your no misdiagnosis, like aortic dissection, and also I think like ACS, I would still be wondering about. So like if there is wall motion abnormalities on the echo, if you see a flap on either the echo or the CT, would be very helpful. Again, I'm still pausing on any management and treatment until we figure out what's going on. So I can't wait to learn from you, and we'll great.
Yeah, I am learning from you all. And thank you, Dr. Ravi, for sharing the case. I'm learning a lot while presenting and listening to you all. So basically, CT was significant for a valvular disorder, could be aortic stenosis. Therefore, cardiology was consulted, who recommended an echo. 2D echo was done, which showed ejection fraction of 65% and severe aortic valve thickening with mean aortic valve gradient of 70, which is normally less than 5 mmHg. That was 70. And aortic valve area was 0.7 centimeters square, which normally is greater than 2 centimeters square. And the patient was basically gently diuresed with 20 mg IV Lasix to avoid sudden drop in preload. And cardiac cath was also done, which showed clinically significant stenosis. And then cardiothoracic surgery was consulted, and she was scheduled for an aortic valve replacement. So the patient was basically diagnosed with severe aortic stenosis.
Oh man, this is so awesome. I think like one of the things that I'm struck by is just like the ability to diagnose a valvular abnormality off of a CT scan. I think it was such a fun game to go through to be like, what are the things that we usually think about on the CT? And in my mind, like I gloss over the cardiac structures because we just have better tests of doing it. But it does remind me of a couple times recently where in Morning Report, some cardiologists who have been in attendance have called out some cardiac findings like, oh, there's some pretty significant coronary artery calcifications here. You can act other times they've been like, you can see this patient's aortic valve calcifications here. And so between those reminders in this case, it's a nice validation of the fact that while we don't use the CT to find information about the heart, oftentimes it still is a place where we can discover it. And then the last thing I would say is just to go back to the very beginning of the case. We said that like sudden onset symptoms can be two things. They can be sudden in onset or sudden to the individual's attention. And I think if we think about the natural history of aortic stenosis, we know that it tends to remain asymptomatic for a very, very long time. And then people start to fall off a cliff as the disease reaches a significant level of severity. And when I say fall off a cliff, what we mean is their ability to compensate for that aortic valve stenosis rapidly goes away, and symptoms can start to develop quite suddenly. We usually start to see shortness of breath. Actually, I don't remember the exact symptom onset, so I'm not going to go through that. But shortness of breath is one of the original symptoms that we can see when AS starts to become symptomatic. And so in this case, it is interesting to see that this came to her attention very, very suddenly. But perhaps and based off of her history, it has been brewing for quite some time. So yeah, I love this case, Amalpreet. Thank you for bringing it to us, and it's such a fun way to take maybe an atypical way to get at a relatively common diagnosis.
Yeah, absolutely spot on, Jack, with that reflection. The other thing that I'm thinking, she's in her 50s, she's quite young, and she has severe AS. So, does she have like bicuspid aortic valve, any rheumatologic, any like rheum diseases in the past, sorry, like rheumatic fever or something in the past that would like predispose her to the severe aortic AS at the age of 53 would be the other thing that I would be thinking about. Yeah, go ahead, Anil. Yeah, go ahead, Anil.
Yeah, so while preparing the case, the first thought that struck to my mind was because I used to read that in 60 or 70 plus people, we hear about aortic stenosis because of the calcification, because of the increasing age. So when we think about aortic stenosis in a young person, we start to think about various risk factors, like if the cusps are decrease in number of a past medical history of rheumatic heart disease, So those things, they come to mind. And regarding the aortic stenosis, the most common presentations, they are basically syncope or exertional dyspnea or angina. And mostly the patients do not present for a long time. They present very late in the disease course. Why does that happen? Because the heart, it hypertrophies, it undergoes concentric hypertrophy, the sarcomeres are added in parallel, and because of that, the contractile function has remained, and that's how the patient is not having symptoms until a very severe stage. And the very severe stage, as we can see in this patient, the aortic wall area was less than 1 centimeter square, and the pressure gradient was also greater than 40. So it was a severe stage. And that's why the symptoms also came up in this stage. And so that's what I learned. And when the symptoms come, the main treatment is to surgically replace the valve.
Thanks so much, Amarpreet. It's yeah, phenomenal teaching there on this. And as we wrap up here, we'll turn it over to you, Jimena, to take us home with some extra teaching to consolidate learning from the case.
Thank you so much, Amalpreet, for presenting this case. And thank you so much, Jack and Sharmin, for always giving us like super duper masterful pearls that we can apply in our clinical practice. I want to start with the teaching points, reminding us of the excellent framework that Jack told us about a sudden onset of a clinical syndrome. When we think about that, we can think about the diseases that might be at play, and we can say that either something got blocked, ruptured, or we had a sudden discharge of electrical activity. And this is so great because the framework can be applied to many organ systems, and then we can apply it to the patient's current presentation. And just keeping on with this framework, as Sharmin said, that we were dealing with an acute hypoxemic respiratory failure, we can think about two possible causes for this, either cardiac or pulmonary, and we can assess here very important differential diagnosis like an ACS, arrhythmias, a PE, a pneumothorax, and an asthma exacerbation. And in this case, it would be very important to evaluate the vital signs, to do great auscultation, to actually assess if we have bilateral clear airway, and also the ECG. And according to that, we're going to be able to assess the severity of the patient's condition. Then also, Jack gave us like this very cool insight to think about, is this sudden pathology actually sudden in onset or sudden to the patient's attention, which also lead us to actually thinking about what is the patient's access to care, because it can mean that the patient has chronic pathologies that haven't been discovered yet. And when we go to the physical exam, the history of a new murmur is going to be a very important piece of data. We can also remember that whenever we have a systolic murmur, we can think about it being a stenosis coming from the aorta or the aortic valve or the pulmonic valve, or we can have a regurgitation coming from the mitral and the tricuspid. And when it is so sudden, we have to think about papillary muscle rupture that should be in our DDX, and also that can be caused by an MI. But we need to remember that we would be expecting lung manifestations for this. And then when we have a patient with hypoxia and clear lungs, that also reduces the possibility of us having a cardiac etiology. We should consider other more morbid conditions like PE or acute pulmonary hypertension. And they also give us some really cool pearls about the labs, considering doing a CTPE versus a CTA. And that's when we're thinking about that the patient might have a catastrophic intrathoracic pathology. We can decide which one is better. And don't forget to get the ECG, the echocardiogram, do close monitoring, especially for the BP. And in this case, the fact that the patient was stable gave us a little bit more room to actually evaluate the results of all the tests that we're getting. And that's all I had for you guys.
Absolutely brilliant, Jimena. Thank you so much. I'm always so impressed with you all. and how fast you can condense so much teaching points. Incredible. Thank you so much, everyone, for joining us. We appreciate you. Thanks again, Amalpreet, for presenting, Yaz and Jazz for scribing, and Jimena for your wonderful teaching points. We'll see you next time. Bye.